Hi, welcome everybody to Aspire Ed Talk. I'm Dr. Qirui Zheng, currently the Secretary General of Aspire, also the professor at the Taipei Medical University. Today, our Ed Talk, the podcast title is Lifestyle and IVF. As we know, the lifestyle is often discussed in fertility care, but how much does this actually influence IVF outcomes, and what should clinical teams be telling patients? In this episode of Aspire Ed Talks, we are very happy to join by Professor Mark Hornstein, Director of Reproductive Endocrinology at Brigham and Women's Hospital, and a leading voice in reproductive medicine. We will explore the latest evidence on how lifestyle factors like smoking, BMI, physical activity, stress, and even environmental exposure such as EDCs can impact IVF success. So hi, Mark. Mark, nice to meet you.
Thank you, Professor Tseng. It's very nice to see you again, and I'm honored to be here with you on the podcast.
Yeah, I will brief introduce Mark Hornstein. He graduated cum laude in biochemistry from Harvard University, following a Rotary International scholarship at Weizmann Institute at Israel. He returned to Cincinnati and finished his medical education from University of Cincinnati. And then he completed his residency at Brigham and Women's Hospital and Massachusetts General Hospital programs, and the fellowship in REI at Brigham's. And his clinical and research interests include medical treatment of endometriosis, infertility, and ART. He is author of more than 100 peer-reviewed original publications, as well as numerous book chapters and reviewers. He has served as the president of the Boston, New England Fertility Society and the Society of ART. He is professor of OB and Gyne and the reproductive biology of Harvard Medical School, as well as the director of the Division of Reproductive Endocrinology and the director of the Center for Infertility and Reproductive Surgery at Brigham's. Out of his hospital, he enjoys music, travel, and spending time with his family. Okay, let's kick off. Mark, can you briefly share what led you to investigate the impact of lifestyle factors on IVF outcomes?
Yes, the story is actually interesting. Most of my research, and I think that for many of my colleagues, really centered on areas of interest to me and to my colleagues, areas that we wished to investigate. This area of research really came from my patients. And for many years, patients had asked me, what can they do to improve their chances of success in vitro fertilization? And somewhat naively, I always answered, really not much. It's really up to us as your physicians to make the decisions and hopefully give you a good outcome. But after having given that answer for many years, I decided to actually investigate the literature. And what I found is that there's a small but important literature in this area which can guide clinicians. And then to my embarrassment, I found that many of the important papers in this area came from our unit, and some of the larger studies were my own. So a little bit embarrassed, I decided this should be a focus of continued work in our department.
Mm-hmm. So based on your research, which specific lifestyle factors have the most significant impact on IVF success rate?
Well, there's no doubt that the single most important lifestyle factor is use of tobacco. And that's true for both men and women. It's true whether the smoke is primarily from the smoker or secondhand smoke from family members or people who smoke in the area of employment. Most of the studies, and there is broad agreement on this, show a decrease in pregnancy rates of about 50% among women who smoke. There's a significant decrease in IVF success rates if the male partner smokes. And as I think many of our colleagues are aware, the effect is to reduce ovarian reserve. And in fact, women who smoke reach menopause about 2 years before those who do not smoke.
How about the male partner if he is a smoker?
Right. So if the male smokes, there's an almost equal reduction in pregnancy. And some of the research, and this work came out of Germany, that showed even if you do intracytoplasmic sperm injection, if you do ICSI, you cannot overcome the detriment of cigarette smoke on IVF outcomes. We know that cigarette smoke can be, or cigarette products can be accumulated in the follicular fluid. And we have done studies in our unit to measure cotinine, which is a stable metabolite of nicotine in follicular fluid. And higher levels of cotinine seen in the follicular fluid result in decreased oogenesis and actually less oocytes at the time of egg retrieval. So the effects are profound, both on men and on women.
Okay. So how about the caffeine? Because this is our daily drink every day. So how about the amount or the, can you tell us your research or some literature review of this caffeine consumption?
Right. So I think it's very important to distinguish between those who drink coffee or other caffeinated beverages prior to assisted reproduction and then once pregnant. I think all of your listeners, all of our colleagues are aware that caffeine consumption should be greatly reduced among those who who utilize caffeine beverages once they're pregnant. The safe limit is about 200 milligrams of coffee. In the United States, that would be about 2 8-ounce cups of coffee or 2 small cups of coffee a day on average. Tea on average contains about half as much caffeine as most cups of coffee. On the other hand, the literature is quite clear that caffeine consumption prior to IVF cycles and even during stimulation does not influence outcome. And there's several very good studies done throughout the world from different populations that verify that.
So almost no effect of the IVF outcome. That's very important.
Right.
Yeah.
So I think the difficulty becomes in women who are significant caffeine consumers. It may be very difficult to turn off the caffeine consumption at the time of embryo transfer.
How about the miscarriage rate?
Yes, so miscarriage rates are clearly higher in women who consume caffeine once they're pregnant, significantly higher. And that's the reason for the recommendation from a number of societies, including the American College of Obstetricians and Gynecologists, to limit caffeine consumption in pregnancy to the amount that I mentioned before, 200 milligrams per day or less.
So what do you think the physical exercise, okay, something like moderate activity or vigorous exercise, is there any difference to impact the IVF outcome?
So it's interesting. There's a little bit of a discrepancy in the literature among those who vigorously exercise in terms of conception without assistance. And in that case, women who vigorously exercise more than 5 hours a week have some reduction in their pregnancy rates. However, we did not see that in our IVF population. It turns out, though, that the most significant effect in the female is on cardiovascular exercise. I think as all reproductive endocrinologists know, that very vigorous physical exercise, such in marathon runners, leads to amenorrhea, which of course would lead to infertility. But in women who exercise less than that, if it's vigorous exercise, the time to pregnancy is prolonged.
So talking about the exercise, what do you think about the BMI? To thin, to fat, does it will affect IVF outcome?
Yes, there's a very good literature, I think, again, as all of the society members are aware, that elevated BMI, which is a significant problem in the United States, leads to worse reproductive outcomes, more miscarriages, and specifically lower pregnancy rates in IVF. The tricky thing, of course, is how to counsel those patients, because if it takes a significant amount of time to lose a significant amount of weight, let's say for class 1 or class 2, or even class 3 obese patients, those are women who have a BMI of greater than 40, it takes considerable time and effort to reduce their BMI significantly to improve pregnancy outcomes. So this is an age-related recommendation. So there were data from our unit that in general that showed that women who were over age 38 would do better to go through IVF without losing the weight than spend, say, 6 to 12 months to lose the weight to drop 1 obesity class or 5 BMI points. Now, this has changed with the use of the GLP-1, GLP-1 agonists, receptor agonists, because this class of medications hastens weight loss. And patients can lose as much as 20% of their weight in 12 months under medically supervised conditions. So this then shortens the time for weight loss. The downside of that is, again, as I think your audience is well aware, those who use these compounds must stop them 2 months before they initiate fertility treatment or get pregnant.
So can you talking about a little bit about the PCOS, because sometimes these patients associated with obesity. What is your recommendation?
Yeah, so a couple of things. In PCO patients, we certainly recommend weight loss as the first line of defense. Of course, PCO patients with PCO-related obesity suffer from insulin resistance. And it turns out that if these patients lose as little as 5% of their body weight or up to 10%, they may begin to ovulate spontaneously. So in this respect, you cure the PCO. There are good data that the GLP-1 agonists also improve outcomes reproductively in PCO women. And the data are best actually in this regard in PCO women. Another thing that we routinely do for patients with PCO with an elevated BMI is treat with metformin, because metformin also reduces in PCO women pregnancy loss. So the live birth rate goes up.
Thank you. Very good. Yeah. So what about the Mediterranean diet? Because is that helpful, or do you have any recommendation?
Yes. So you're absolutely correct, Professor Sang, that Mediterranean diets have been shown. There are 2 good randomized controlled trials, one from Serbia and one from Greece, not surprisingly in Mediterranean areas. And both showed in patient populations varying from about 200 to 300 subjects, an improvement in IVF outcomes on those using Mediterranean diets. The effect was statistical. It was small, but it was reproducible. What I tell my patients about Mediterranean diets is that Mediterranean type diets may improve IVF outcomes. But even if they don't, they are diets that are cardiovascularly healthy. So the mainstay of a Mediterranean diet is the use of vegetable oils, in particular olive oil, lean meats, fish, fruits and vegetables, and an important part of the Mediterranean diet, which is often forgotten, is legumes, which are beans, lentils, and nuts. So this is a cardiovascularly healthy diet. It would put patients in good position for pregnancy, and it may actually improve IVF outcomes.
I think the other important factor is environmental exposures, such as BPA, phthalates, dioxin. I think they are all increasing recognized as factors in influencing reproductive health. What is your opinion? How do you think the provider should realistically approach the discussion about these EDCs in infertility care?
So the problem, for example, with BPA, which is very well known to be an endocrine disruptor and affects reproductive hormones adversely, particularly estrogens, phytoestrogens. The problem with BPA is that BPA is ubiquitous, at least among the American population. So there are studies among the US population, among adults, that show well over 90% of US adults have BPA in the urine. So pretty much everyone is exposed to it. The major exposure tends to be in plastics, soft plastics like bottles. It's also contained in other soft plastics such as IV tubing. And it's been detected in neonates in the intensive care unit in their urine because they get it through the IV tubing even during the first few days of life. The problem is that the exposure is always there and it's very difficult to avoid. It stays in the human body. So once you have BPA, you're not likely to get rid of it. Now, work done by Dr. Catherine Rakowski in our unit and her team had shown about a decade ago that the effect of BPA is to disrupt the spindle in the human oocyte. So we know some of the mechanism of action of this class of drugs. I would say that environmental toxins in general continue to be an increasing concern across the globe as we have continued industrialization of many of our countries. All humans are really exposed to these pollutants. And I think a lot of the effects reproductively are unknown.
So it seems to be a long-term problem because the half-life of these EDC is very long. For example, dioxin, the half-life may be 7 to 8 years. So the long-term effect is tremendous. We should be very cautious. Yeah. And,
I would agree with you completely. In fact, some of the endocrine disruptors are often referred to as forever chemicals because once they're in the water system, they're basically there forever.
Yes. I remember you give a talk in Hong Kong of Aspire meeting 2019. And remember you talk about the TV watching. Is any relationship to the fertility potential?
Yeah, it was one of my favorite studies. It's a small study. It was part of the talk that I gave in Hong Kong, and you have a very, very good memory, Dr. Sang, on activity of the male. And it turns out that men who have reduced physical activity have lower sperm counts. And there was a study out of Rochester, New York, which is not far from where I am now in Boston, Massachusetts, that looked at men in terms of their level of activity. And the highest sperm counts were men who had the highest exercise during a week. And the lowest sperm counts, as you recall, were correlated with the amount of hours of TV watching that the men did. So we encourage the partners, the husbands of our patients, to watch less sports on television and get outside and do more sports themselves.
So how about the counterpart, the woman? If they watch TV longer, is also the same detrimental effect as men?
I guess I would say in an evidence-based way, we don't have the data.
Yeah. So the next question I would like to ask you is, what practical advice would you give to fertility specialists who want to better address lifestyle with their patients, but are not sure where to start?
Well, I think there is a literature on a number of these areas, and you have touched on a number of them. So I think it's important to be able to counsel patients about the things that they can do. In my experience, and that of many of my colleagues, at least in the United States, patients are very, very interested in partnering with their fertility physicians to improve outcomes. And I continue to be asked, what can I do to improve my outcome? So knowledge of what the evidence is in our literature is very helpful, because in an evidence-based way, we can counsel patients appropriately. And in my experience, this is information that the patients seek. They get on the internet and other sources a lot of bad information, a lot of information that is incorrect. And to the extent that physicians who see these patients can counsel them appropriately, I think that's to everybody's advantage.
Mm-hmm. And last, I would like to ask you, if you could improve one aspect of how lifestyle is handled in IVF clinics globally, what would it be?
I think if I could answer with two thoughts.
Yes.
Certainly, as you asked and we discussed in considerable detail, use of tobacco is terrible reproductively. So basically, any patient who wants to conceive needs to stop smoking. And as physicians, I think we should have the obligation to encourage our patients to do that and utilize resources within our hospitals and clinics to help patients and their partners achieve that goal. That will definitely improve their reproductive outcomes. And as we all know, smoking during pregnancy is terrible for the fetus and ultimately the baby. So, we can help reproductive outcomes in two ways. I think the second way, Dr. Seng, I would answer the question is related to your questions regarding obesity. And if we can encourage patients to lose weight, adopt a more healthy lifestyle, we know that not only will they have better IVF outcomes, they will certainly have much better pregnancy outcomes with less complications for them and their babies. And as we've talked about, weight loss and healthy lifestyles is good from a cardiovascular point of view, which ultimately means not only will these men and women have the babies they desire, but hopefully their lives will be lengthened and they can spend more time with their children.
Yes. Yeah, I think time is almost up. Thank you so much, Professor Hornstein, for very fruitful and very constructive ed talk for Aspire. I think everyone, if he is physician, embryologist, or a fertility nurse, this conversation offers practical insights on how to integrate the lifestyle guidance into our daily practice and improve the patient care beyond the laboratory and the protocol. Especially today, Professor Hornstein talked about lifestyle factors modification, like BMI, smoking, physical activity, and maybe some diet, environmental exposure, toxins. They are really affect the IVF outcome. So thank you so much, Professor Hornstein, to join this ed talk. We hope to see you near in the future in our Aspire annual Congress. Thank you.
I hope so, and thank you for the great privilege of sharing some of the work that we've been able to do in our unit.